to start here with a little bit about you and your career to date. So do you want to just provide a general overview of your journey leading up to your current role, and correct me if I'm wrong, as the Director of Clinical Research for the Lank Center of Genitourinary Oncology at Dana-Farber Cancer Institute?
Yeah, so it's hard to believe I've been there now for 8 years. I got there in 2016, but I took an unusual path from academic medicine standpoint. So I was, my dad was in the Air Force, so I grew up as a kid, and when it came time to think about going into medical school, I enrolled in the HPSP program, which is essentially like the ROTC program for doctors, where the Air Force will help with medical school tuition. So I went to Tufts for undergrad, Tufts for med school, and then through that scholarship, I went for my residency choice, and they said, oh, you're going to join the military for residency. So I was actually in San Antonio for my residency, ran into fellowship, and did 6 years as active duty physician in the military, serving in Texas and California. I actually went to Afghanistan for a brief stint, and my time came up, and I was doing general oncology, right? And so I knew I could be a really good general oncologist, but you can't be an expert in general oncology, right? Because you can't know the data on every single trial all the time. You can't give all these drugs on a regular basis so you feel really comfortable. And so as I was thinking about what I want to do, I knew I wanted to sort of start specializing. And GU oncology was sort of a nice transition point from doing everything to doing 3 to 4 different disease types. And then over time, I was hired purely as a clinician. I've sort of evolved into a clinical trialist, and really a lot of my research efforts are focused on bladder and kidney cancer.
Were there any early experiences in the med school journey? Were there any particular mentors or anybody who you can credit to pushing you towards GU Onc?
Yeah, there's clearly reasons for going to oncology. From my childhood, my dad actually had ALL when I was 10, and he actually got cured through aggressive chemotherapy regimens. It's crazy, the nurse, when I did my fellowship, the nurse leader was actually my dad's nurse when he was there. So it's small world, right? In terms of going into GU specifically, it's hard to say there's one key aspect. I think there's been so many mentors along the way that helped my oncology career and got me to where I am today. And then really it was a little bit of happenstance, right? That I was looking to move back to the East Coast, interviewed at Dana-Farber for GU position again, which had that nice transition point. And then through that experience, it's sort of seeking opportunities that come up, right? So as I was over there, at the time, really no one was specializing in bladder cancer in our group. There's sort of a lull, and so I was able to lead the EV201 trial for our site. We were the lead accruer internationally for that trial, and so really sort of just seize the opportunities that come along, and by just being open to those opportunities, it really has helped my career sort of get to where it is right now.
So let's talk about right now then. On a day-to-day basis, how would you describe your current responsibilities? Maybe, break out from a percentage standpoint how much time you spend in clinical care versus research versus administrative.
Yeah. So I think to be a clinical trialist, you have to do clinic, right? Because you can't be a clinical trialist and not see patients in the clinic, because as a clinical trialist, we want to, provide care for our patients. So I'm in clinic 2 days a week, at least, and I probably have a couple of extra visits here or there, and if I'm away from meeting, I'll see patients. So 2 days a week in clinic, and then the rest of the time is spent on a variety of different roles. So I have administrative roles at the Institute where I sort of oversee the clinical trial operations for our group with our research managers and the regulatory team, sort of what trials do we want to invest in our group, how do we want to sort of allocate resources and sort of continue to advance care from the GU perspective. So we have over 20 trials that are open at any given time. And so that's sort of a lot there. And then beyond that sort of research sort of role, obviously I'm involved in my own clinical trials, right? And trying to think about how can we, take this trial, writing investigator initiative trials, collaborating with the industry to make sure we have the right trials at our site.
So then I want to ask you mentioned EV201 as, a significant trial in your professional life, right? And you've got 20 ongoing at any given moment that you're, coordinating. You have your own as well. I want to know, in your opinion, what would you consider maybe to be the the 2 or 3 most impactful studies or research contributions that you've given to the bladder cancer field in your career?
Yes, I mean, I think being part of EV-201, right, which has led to the FDA approval of enfortumab vedotin for metastatic urothelial carcinoma was really exciting, right? So we were using this drug that's a game changer, and we got to use it years before it got approved by the FDA. So, it was no surprise when we see all these exciting results come along. So I think that was fascinating. And then being able to build upon that, so I think one of the more exciting stories I've been able to help lead and get out there is our DAD trial, the double antibody drug conjugate, where it was the first trial ever to combine 2 different ADCs, not just in bladder cancer, but actually in any malignancy, right? So we showed that EV plus SG could be given safely with GCSF support with a really impressive response rate, 70%. Small numbers, but 70% objective response rate. And I have several patients that are off therapy for over a year, 2 years without any progression disease. So really offers a paradigm shift, right? Can we combine ADCs together? And that's sort of the foundation. For us, we're doing the DAD-IO, so DAD-IO, or adding pembrolizumab to EV and SG. But I'm getting calls from investigators in lung cancer or other things. Hey, we want to think about combining this ADC with that ADC. What was the rationale for that? So I think that to me is really exciting. As we enter this era of ADCs, we haven't combined them at all. And so I think what we showed is that rational combinations of ADCs with different targets, different payloads, non-overlapping toxicities can be done safely. I think it's really exciting to think about the next steps.
Excellent. And you and I have spoken about the muscle-invasive space and how it figures to be quite exciting over the next few years, maybe even within the next year or so.
Yeah.
So I was hoping maybe you could speak to what are the questions to be answered, what are the therapies, or how are these questions attempting to be answered, and what is the timeline for getting some of these solutions? Yeah,
I mean, I think urothelial carcinoma, after decades of negative trials, has had this revolution of advances, right? I mean, we had a standing ovation for the data for EV plus Pembro at ESMO last year. And I think all these advances we made in the metastatic setting are going to be making their way into the perioperative space, right? So just in the past year, we saw data that pembrolizumab after surgery high-risk disease improved disease-free, relapse-free survival. We saw the data for adjuvant nivolumab after years of follow-up that there was a trend towards improvement, not just in relapse-free survival, but overall survival, which is fantastic. And so that's obviously shaping how we think about it. It says IO probably has a role in that adjuvant space. But there's a lot of trials that are ongoing looking to change the preoperative and operative, right? The whole perioperative space overall. We've had a press release, the NAGRA trial, that adding durvalumab to cisplatin-based chemotherapy improved overall survival. And this is on the first analysis, right? So we've had years of follow-up for adjuvant nivo, and now the first analysis is an OS benefit. So we're looking forward to seeing that data at a future meeting. But there's other trials with cisplatin gemcitabine and nivolumab, cisplatin and pembrolizumab. And then on top of that, now we have data with EV Pembro trials that are being done. And those EV Pembro trials are really exciting because they're going to offer an option for patients who cannot tolerate cisplatin, right? So right now, it's a situation where if you can't get cisplatin in that perioperative space, we do surgery and we sort of assess, right? But now, if the EV Pembro data is able to translate into that perioperative space, we're going to hopefully be curing more patients in that perioperative setting because we're going to be able to offer more patients therapy before surgery. And I think that is going to be a huge game changer because not only are we going to hopefully improve outcomes, if the trial is positive, but we're going to have a new option for patients that otherwise would not be able to get therapy. So I think it's going to be a really exciting time. And my hope is that all these advances continue to move forward, and all these advances made in metastatic setting will be important. They'll be less important because hopefully we'll be curing more patients in that upfront setting and eliminating the need for therapy in the metastatic setting.
Or even prior to surgery in some cases, right? So,
right.
Absolutely. So last couple of questions and taking a step back. You come to these meetings and you hear quite a bit of discussion about the GU oncology practice in general and where the field is heading. And I want to know, in your opinion or in your own words, what are some of the most pressing issues or challenges currently facing the GU oncology field? Is it a lack of manpower? Is it accessibility or availability of therapies? Is it anything in the clinical trial world? What's the largest issue facing the field today?
So I think we're very fortunate within GU Oncology. I think it's a very collaborative group, right? So we work together, we come to these meetings, and part of the reason we come to the meetings is to hear the data, but also just to meet in person and collaborate and get new ideas. And I think that post-COVID, having these meetings come back and in person has really been helpful to sort of stimulate some of those conversations and keep those ideas, those flames ignited and move to the next step. So I think that is something I find incredibly rewarding about academic medicine and oncology. I mean, obviously, I think there's probably not any challenges that are unique to GU oncology versus oncology in general. I think, obviously, the big issue is going to be making sure that clinical trials are moving forward. We have the infrastructure in place to support the clinical trials, right? There was a long time where infrastructure for clinical trials, research coordinators, all that, it was understaffed, right? I think that's improving at this point in time, but making sure, clinical trial operations is not just the doctor and the patient, right? It's the doctor, the patient, it's the research nurse, it's the research coordinator, it's the regulatory team, it's the data entry, right? So there's so many factors that come into play, and so making sure we have that infrastructure in place, not just at the major academic centers, but like across the country, so that patients, wherever they can enroll in clinical trials. And I think we're starting to think about that. I think COVID taught us that telemedicine has a role. We can start thinking differently, and so hopefully we can sort of apply those lessons as we sort of look to clinical trials to continue to improve accessibility, because I think underserved populations are underrepresented in clinical trials, and so applying some of the data we see to those patients is always challenging. I think as a field, not just GU oncology, but across the board, we need to continue to improve efforts to enroll patients across all the spectrum.
I think that's very well said. And the last thing I want to ask you is, in a leadership position like the one you're in, what comes with that territory is, I guess this isn't something that you see on your resume necessarily, but you are an educator and you are a mentor to probably quite a few people. So I want to ask you, in your own estimation, what advice would you give to aspiring GU oncologists entering the field today, the young upcoming generation?
Yeah, I think when I think back about my career, I think one of the key things I remember from the very beginning of my fellowship training was Dr. Mike Oswald. He was my program director in the military. And I remember I had a patient, I was presenting to him, and I was doing this whole thing, and he just stopped me in the middle. And he's like, what are your goals? What are you hoping to achieve for this patient? He's like, you always want to have a goal going in, right? Is this curative? Is this not curative? What are you looking to do? And so as I see a patient in the clinic, I always say, what is my goal here, right? Is it cure, is it not cure? But you can take that to the next level. As you think about your career, what you want to do is what are your goals? What is a realistic goal? What would you want to do 5 years from now, 10 years from now? When I started Dana-Farber, I interviewed, and I interviewed for a clinical position. And well, what do you want to do? I said, well, I want to be a good GU oncologist in the clinic. And I said, but in 5 years, I want to be a clinical trialist. And they're like, no, just focus on the clinic, right? But you have to have those goals. They may seem unrealistic. People may not think of it there, but have those goals and just work your way to them. And sometimes, you may have a strange path, right? My path is not the traditional path for academic medicine at all. But I got there, right? And it's just because as you go forward, you have that goal and you just have to keep an open mind, right? And say, okay, early on, your reflex should not be say no. You can't say yes to everything, but you have to sort of be open to opportunities, because you have no idea where that opportunity is going to take you. And so sort of keep an open mind. If you go into a position and say, I only want to do this, well, it's much easier to find a niche than to create one, right? And so if you're open to opportunities, say, oh, there's something that needs to be done that I can fill, you're going to have a much more successful run than if you're trying to fill something that's already been done, because then you get into competition and it's more problematic, right? So I think being open, having an open mind, looking to what are the unmet needs and trying to fill those is going to be the secret to success, and just being patient. It doesn't happen overnight, but it does happen.